Shakib, ready? Who wants to join? Sendil, do you want to go ahead or?
Yeah. Sure.
Shakib, do you want to go ahead?
Shakib still having his technical challenges, I think.
Okay.
Technical support. Needs technical support.
Phone a colleague. If it's a social hours, call a colleague.
Sanjay, you on call tonight as well?
No. I was on call yesterday. I just had to give one off back to my colleague who gave an on call for me before the part one in February sometime.
Okay.
While, so.
Nice.
Okay.
Okay.
Yeah.
I think we've all been in one cycle of nights. I did one set. Varun finished one set. You finished one set.
Prashant is joining us. Welcome.
Yes, sir.
Oh, Prashant. Welcome, Prashant.
Excellent.
Hello. How are you?
Fine,
Oh,
fine.
Prashant is here as well.
You're gracing us. While you grace us, you may as well tell us about the exam and whatever.
I'm just trying to help you guys. Come on. Congratulations, Prashant. Well done.
Surprising visit to our session.
Thank you, guys. Thank you so much. Thank you, Sakib.
Thank you, Sakib.
Yes. Thank you, Arun. How are you guys?
Tell us about your experience and
How was your post-exam feel?
I'm so relieved, on top of the world, honestly. After I gave that agonizing viva on Splenenculi for 20 minutes, not just me, even the examiners were staring at the ceiling for 20 minutes. What to talk for 20 minutes?
Did your short test?
It was a long case, yes, Splenenculi. The examiners were trying to confuse me by saying it's the left lobe of the liver. I told them, listen, I may not know anything about Splenenculi, but I'll tell you one thing, that's not the left lobe of the liver.
CT, right? They were showing CT.
So it's very systematic. I don't think they want to know how well you know things. All that they need to know is how you reach the end point and how are you going to manage this patient. I don't think there is a right or wrong answer. Obviously, if you're massively wrong, then it's a different thing. But all that they need to know is how is your systematic way of approaching things, and how are you thinking in managing the patient, in investigating and managing the patient. That's all that they need to know. Because for this Splenenculi thing, so it all started with it was a pretend patient, and they said okay, for a 50-year-old lady with
just a second, I'm going to stop you here. Don't say reveal the scenarios.
Okay.
Make it as a session. Who wants to go ahead?
No. Listen, I'll take this as a station properly next time. But today I'm just joining in
No. You. I think you just brief us.
Sessions then.
If Varun, let him brief. It's okay. We'll do it.
No.
Again.
Keep it informal.
I think I've told this to only Varun. I haven't told this to anyone. So next time I'll take the station. I'll prepare the questions properly and I'll take the station. That's fine.
That is better actually.
See, it's not what the answer is, it's how you get to the answer. So it doesn't matter if
Exactly. Yeah. Because I know how massively lost I was in that station, but the results showed that I scraped through. So I think I've come to that inference that how you reach the end point is what matters, not whether you're right or wrong.
Good. And how much time do you have during the exam? Session is like all block sessions or get a break in between?
No. See, yeah, it is block stations, and between two blocks you may have some time off, but in a block there is absolutely no time, and they strictly adhere to the time. 5 minutes means 5 minutes. Well, how much progress you have made that 5 minutes is up to you. So I wouldn't advise you, faffing about. Just go on, cut.
Yeah.
Just tell them, because
just don't beat around the bush.
Yeah, even they are time bound, so even they have to see that they progress. So I would strongly advise you, think very quickly give them an answer, move ahead.
And
And-
Prashant, in one 5-minute station, how much questions generally on average they
So
ask?
it all depends on you, Sakib, how much progress you make. And if once the point reaches where they start asking you about trials, that's the when you should heave a sigh of relief. Sit
And
down.
what do you think what do you think when does this point reach? After 8 questions on average, 7, 10, or maybe more than that?
No, after 4 or 5 questions in 5 minutes, there is no way you can reach 7 or 8 questions.
Okay, makes sense.
Yeah, but
Makes
once you reach that level, that's it. You can heave a sigh of relief, sit back, and give whatever answer you want to give. Then.
So that's for the Viva, is it? Prashant?
Yeah, that is for the 5-minute Viva, and yes, you also reach the point of trials in the 5-minute Viva, and that means your Viva has gone extremely well. For the 20-minute, it will be very agonizing. I mean, if you don't know anything about the topic, it will be very agonizing, because then 20 minutes will seem like 20 years. And if you're doing extremely well, even those 20 minutes will pass by very quickly. Like for my academic Viva, I was asked trials about another paper related to the same topic. So that was extremely, it went extremely well, the academic Viva.
You mean the academic event? You mean the paper session? The
The paper session. Yeah, paper session. I just told them this is a bullshit paper, and I wouldn't. And so he asked me, so what is? So I knew the impact factors of British journals, but this came from American Journal of Surgery. So they asked me, do you know what is the impact factor of this? I said, honestly, I don't know, but if they published this paper, then it wouldn't be that great. He started laughing. He said, yes, I agree with you. This is a very bullshit paper. But yes, academic guys, academic paper is what is your scoring point, and honestly, it doesn't take much. Those. So I did only cracking the intercollegiate, and the academics Viva section in that. If you study that very well, you should be okay, and you'll score really well in academic Viva. But again, the main crux of academic Viva is how well you can read a paper, how well you can analyze and describe a paper.
It's more of talking about the paper.
It's more about talking about the paper, but these guys, they get bored because they have to listen to many candidates talking about the same paper over and over again. So there are two kinds of ways. One set of examiners will just tell you, okay, fine, tell me about the paper, and then you go about the paper. The second, which I received, was like, don't tell me anything about the paper. What do you think about it? That was my first question. So in that case, you have to be ready with a summary, not what is written in the paper, but what do you think about the paper, and you have to summarize it in very small. So this was a paper on this. They evaluated this. These were the methods. These were the results.
Are you allowed to see the points and read it out with the paper, or are you supposed to do it without your paper in front of you?
So the paper is with you. I carried markers with me, 1,000 different colors, which the examiners were astonished on seeing so many colors. But they give you colors there anyway, and they give you some 3-color highlighters there, which you can use to highlight it. Some candidates use just green and red. Green for the good points, red for the bad points. But because we had around 30 minutes and more probably, to get inside, so 5 or 10 minutes more. It's very good to use that time to make a summary in your mind. And as soon as I sat down, he asked me, what do you think about it? So I asked him, is it okay if I refer to the paper? And he was like, yeah, that's fine. I told him, is it okay if I refer to the paper for numbers, to get the numbers right? And he said, yeah, that's fine. But then thankfully I didn't have to refer to it, because I had memorized the numbers in those 35 minutes, and it was good. Because then you don't waste time sifting to the papers and seeing, where the numbers are and what it is about. So just the salient points, memorize it, keep it, go there and tell them this is what it was. And so I still know the numbers. They analyzed some 21,000 patients from their directory.
pictorial memory then.
Yeah. So it was good, and then you just say, and it was I can share the paper, and I can take a viva for you guys later on based on the same paper, and we can do it. But it's good to have the numbers so that you don't waste time sifting through the paper, because honestly, in the stress of the exam and having the examiner in front of you and you trying to see to it that you don't waste time, you will get lost even if you have marked it with numbers and all.
What about the second part of your academic viva in terms of like physiology and anatomy?
Yeah, so that went extremely well, and that's where again I was asked about trials based on those. So I won't tell you the topics. If you want me to grill you sometime later on that.
Don't reveal the topic, just the.
Yeah. So but that also went well, and that was very quick. So once you go through your academic viva, then you have only 5 minutes each for the rest of them, and that goes extremely quick. And again, I was asked on trials on those also. In those 5 minutes. So once you come to trials, you be rest assured that you have just
Yeah.
Yeah. So
long case and short case.
So
your long case is spin and fly then.
Yeah, but I was completely screwed. So this was I'm coming from, like, for the past 6 years now, I've been working in HPB. And my entire, so one was on spleninculi, the other one was on so I can tell you this, but it was completely on bariatric and achillesia. So I was completely screwed in my specialty long case. I came home extremely depressed, and that was my first day. However, I talked to a few friends, and they said, like, this is the main thing. Like, now, if you lose your plot here, then the next day will be completely gone, and be rest assured you'll flunk. So you have to make sure that your previous performance doesn't affect you. Otherwise, because the next day also is 75%, 60-75% is next day. You have to see to it that you score. And you
has got the weightage? Is it the long case, short case, general surgery, or is it the viva? Do they have any weightage for each and every?
So long case will obviously have a high weightage compared to short cases. Otherwise, it wouldn't be a fair examination. But
the marks are there in the beginning of cracking and FRCS combined in Part B. They break down the marks of each section.
Yeah, and I think, but still, at the end of the day, it all depends on how well you do in your specialty. I think so. I don't know. I'm sure they have a secret marking system or something, because I know someone who's flunked for 3 times in a row, and all the 3 times he hasn't done well in his specialty. So I have a suspicion that your specialty still has a
weightage.
Higher weightage. Yeah. And I was thinking that because my entire specialty was on spleninculi, achillesia, and bariatric complications. I was like, this has nothing to do with HPB, and I was like, by the way, so when I got up after that agonizing 30 minutes of my subspecialty, I apologized to them. I was like, I'm really sorry. We both had to go through this, but this is not my specialty. I'm HPB. So they started laughing, and they said, no, but it's still upper GI, and you still have to, you still have to appear. But for Senthil and Sanjay, I don't think you have to go through this. So I think they have divided it now, isn't it?
Yeah, mine's only HPB. Hopefully,
good for you. Good for you. I was cursing myself. I was like, why didn't I sit in September with Senthil? But yeah,
I'm colorectal anyway.
Oh, you're colorectal.
Yeah, correct. Okay.
Very nice.
Right.
2 colorectal, 1 HPB, 1 upper GI.
Yeah. Yeah. So I don't think any of you will have to go through that. It will be very systematic and score. But for my bariatric complications, don't think that the next scan is going to be related to what was previously.
I heard that kind of scenario, because
they will throw you off. Every scan they showed me in that 5 minutes was of completely different person, and you are thinking that it belongs to the previous person. No, the scan will not be related to the previous. okay, so they told me this is what has happened. This is the X-ray. What do you think? And I said, maybe, it's a gastric band slippage. Maybe this, I'll have to calculate the phi angle and this and that. They said, okay, fine. You have done all of this. Now this is the upper GI endoscopy. And the upper GI endoscopy was not related to the gastric band. It was ulcer. And I was like, well, this doesn't look like a slippage or a erosion. It looks like an ulcer. I can't see the band in the stomach. And they said, okay, so no, this is ulcer. What will you do? And then I was like, well, I'll do biopsies. Okay, where will you do biopsies from? And I said all of that. What will happen if you take biopsies from the center? I was like, it will be necrotic. It would be non-represented. And then next CT scan was of that this patient has had a CA stomach. For someone who's lost, he will be like, no, this is still slippage. This is still slippage. This is still erosion, and he will go with what he said in the first when he was showed the first X-ray.
They change the scenario for each and every second. Like
they won't probably
jump from one thing.
The scenario is a long case, is it?
No, this was 5-minute short case. The scenario won't change. The imaging and everything will change. So you'll have to go on changing your diagnosis of what you feel depending on that spot evidence that you have been given, or spot scan that you have been given, or spot whatever investigation you have been given.
I think I did a session with Saqib long back, like probably a month back, with an half-an-hour session. Do you remember, Saqib? Like it was like a 30-minute session. We jumped from one scenario to other scenario, like 5 years. Do you remember that day? Like you were, you had a great sigh of relief after the 30 minutes.
Yeah, but I think the Viva sessions with you guys helped me a lot, because as you know, I haven't done any of the courses, Vips, Crofts, Alpine, or any of the courses. Even the virtual courses, I haven't done any of them. So the only thing that I did was with you guys, and I think that helped a lot. So thank you guys.
Probably we should clear. That's more important now.
That's
important question is, where's the party?
Whenever you guys meet, let's meet. I think we'll do a combined party after September, because I'm very sure all of you guys will clear the exam. Many people went on YouTube. I didn't know that these sessions were recorded. Many people went on YouTube and said, Prashant, we saw you on YouTube, and it's a miracle you passed. I was like, yeah.
No, that's why I said you. Even before starting the session, I said, shall I record this? Because people, people they make money out of this kind of discussion. So let someone be enjoy these sessions. It's not for us.
Prashant, good thing the examiners didn't see the YouTube sessions.
Oh yeah, absolutely, man. Absolutely.
Doesn't matter. Don't worry. Like say they know. See, all the people, those who are running the courses, are one way or the other, they are the examiners.
Yeah, true. See, that's what I think. Senthil and Varun. I think every one of you should have more emphasis on the way you talk and the way you present. I think that is the most important. I think they have already evaluated your knowledge in FRCS part 1. Part 2, they aren't exactly evaluating, how much you know and how great a surgeon you are. That's immaterial. All that they need to know is, how are you going to, talk to this patient, assess this patient, manage this patient, and whether it's safe. If it's unsafe, there's an outright 4, and I don't think there is any, any point even, because I have been told that if there is a 4, outright 4, then the rest of the exam is immaterial and you flunk anyway. I don't think any of us is into that category of getting a 4, because that would mean that you are hellbound on killing the patient. And that's an outright 4. I don't think anything else is a 4. Everyone will get either a 5 or a 6 bare minimum, and all of you guys, I'm sure you will get at least a 6 or 7 for all of them, and maybe even 8, of course. Once it goes to trials, it's an 8. And I've been told that this in this exam there were quite a few examiners who were very nice, and they were giving 7 and 8 for most. As long as you have approved that you're not hellbound on killing the patient.
What's the pass mark, Prashant?
6.
Yeah, you have to get
7 is average, 8 is excellent.
Yeah.
And below, I think 5 is fail, 4 is you are not fit for anything. They'll inform the Royal College. They'll inform the CMC.
So 5 is borderline fail, 6 is borderline pass, 7 is you're quite fluent, and 8 is you're excellent and probably know more than the examiner. So that is how it is.
So Prashant, can you take us through the all stations? What were you asked? Just the heading.
This is recorded. I don't want to reveal anything from.
Okay. Yeah, sure.
All right. We can do it some other day.
So why you're putting all that stuff in the YouTube, man?
Yeah, that's what I'm saying. This is recorded. See, everyone is. It's not only you and me are discussing. There are plenty of people probably maybe watching this or hearing to this. I don't know how many are doing it.
No, yeah. I don't think we should be discussing any questions or any exact questions.
See, Prashant, none of the candidates, those who are discussing here, have not even attended the exam. So it's immaterial. Like whatever we discuss, it's from the cracking, it's from the top of the head. What could be the thing? What could be the thing? No one can blame that you have discussed this as if it was there in the exam.
Yeah, absolutely. What we can do is, I can make some stations, based on what I have been asked, based on not exactly, and then we can go through it. Yeah. But as I said, knowledge-wise, everyone is up to it. It's up to how you present and how well you demonstrate that you're safe. That's it.
Damn. All right. Shall we go ahead with the scenarios then?
Sorry?
Yeah.
Good. Senthil, do you have any scenarios with you?
I
have
Who's going to be the examiner? Who is going to be the candidate? I've got few.
What have you got?
But let us stick on to the time, guys. I think we have to be more precise in the time.
So I have a good HPV scenario if Senthil you want to take.
Leave.
Yeah, I don't mind.
But we can do it later as well. If you have a good scenario, we can discuss that one.
Just a second.
No, just start. We'll discuss all of them.
Prashant is going to leave us.
No, I'm gonna be here.
Oh, all right. Okay.
And I can give my inputs as and when needed. But next time next time I'll prepare some scenarios and I can take a.
Oh, thank you.
Varun,
Yes.
Can you allow me to share the screen, please?
Yes. Yeah, you can do it now.
So it is a HPV, not a HPV kind of scenario. It can come, with the slight change of theme, it can come into upper GI, it can come into the colorectal, it can come in any session, to be honest.
I'll take the scenario then.
Yeah. So it can come in any section. So Senthil, this is your scenario. Right. Can you see the screen, please?
Yes.
Okay. So Senthil, you are doing a laparoscopic pancreatico-duodenectomy, classical Whipple operation. And the patient had, it was a very difficult surgical field because of the inflammation. This patient had preoperative CBD stenting as well for obstructive jaundice. While you were dissecting near the inferior border of the pancreas, you anticipated bleeding, and it is about 400 mils of blood that was lost during this dissection at this step. What options you have now for this patient?
Right. At this point, I'm concerned about controlling this bleeding as soon as possible to stabilize the patient. I will inform the anesthetist immediately that we have a situation where we have some blood loss so that they can prepare from their end and keep a close eye. At the first instance, my reaction will be to understand in that area what can possibly bleed. It could be venous, it could be arterial, probably branches from the superior mesenteric vein, possibly from the superior mesenteric artery, either first jejunal branch or the inferior pancreatic or duodenal vessels, or it could be just small branches of these. I will try and see if I can apply pressure. I'll try and anticipate if it is venous or arterial bleeding. Apply suction and ask my assistant to retract and get everything in place to assess if it's a small branch, whether I can apply a suture and try and ligate and control the bleeding. If it is more massive than that, then I will have to try and see if I can get further proximal, if I can gain control of the superior mesenteric vein, and if it comes to it, apply a vascular clamp to see whether that can give me an idea as to where this bleeding is from, and then control it with the help of sutures. Yes, I mean,
okay, so you applied the pressure with the help of a swab. You did the suction, and try to take one laparoscopic suture from the possible venous bleed, but the bleeding did not stop. So what are the commonest site of bleeding you are anticipating in these areas?
So at the inferior border of the pancreas and near the uncinate, I would anticipate bleeding from branches coming off the superior mesenteric vein, and branches of the pancreas draining into the superior mesenteric vein rather, as well as branches that are rising from the superior mesenteric artery, first jejunal branch beyond the pancreas. Less likely near the head, but more likely towards the body or towards the neck than whether there is splenic vein involvement, less likely to be splenic arterial involvement. And I would keep a very low threshold now that I'm not able to control the bleeding to obviously convert to an open and then to tackle the bleeding.
So what is the anatomy of middle colic vein and GDA artery?
Gastroduodenal artery branch of the common hepatic gives from the celiac axis you get the common hepatic artery, and then after the branch of the right gastric you get the gastroduodenal artery coming right off the.
Which is the first branch? You think that the GDA arises first or right gastric artery arises first?
The right gastric arises first, then the GDA. No, I'm sorry. The GDA arises first, then the right gastric.
And what is the anatomy of middle colic vein?
Middle colic vein drains into the superior mesenteric vein.
And what are the tributaries it takes before draining into the superior mesenteric vein?
Second.
Okay, you did all the methods, but bleeding did not stop, and it is about 800 mils of blood that have been lost. And what approach you are going to do? Whether you will continue the laparoscopic approach at this point, or you will decide to convert it.
At this point, I will convert to open. I will consider how much help I have in the theater in terms of if I have a senior person with me, or I will ask for help to see if there's a senior colleague who can come and help me with this case. But I will start prepare to open this patient and control the bleeding.
Okay, and what are the options you are going to use in controlling the bleed, which was not controlled on the laparoscopic approach?
I think I'll be able to apply pressure better. Two, I will be able to get my hand around, depending on how much I've mobilized the duodenum and the head of the pancreas, I'll be able to get my hand towards the lower end and try to compress it between my fingers, which I would not have been able to do laparoscopically. So that usually helps to tampen out the bleeding and to assess where it's coming from, while you can decide how to tackle it.
You have opened and you have now done a laparotomy, and you see that the bleeding was from the junction of middle colic vein to the superior mesenteric vein. how you are going to manage this patient now, this bleeding now?
Um, it, I'm. It is obviously a very critical junction. I will have to consider possibly ligating the middle colic vein flush with the superior mesenteric at the cost of losing the middle colic vein, which is may cause some congestion to the gut and the colon. But if it is possible that it's a small rent in the vein, I will try to um, if I can get proximal control of the superior mesenteric vein with a clamp, I will apply that and then try and take sutures, fine vascular sutures, to try and seal the bleeding without compromising.
Okay, so Santil, at this point, the patient has is stabilized. The patient's hemoglobin is 95, and the blood gas show the pH of 7.35. Patient temperature is 36.5. My question is that next question is that what was the next question? Will bleeding apparently stop and these parameters, will you continue resection or you will stop?
I'll wait for the anesthetist's opinion in terms of obviously whether it is just stabilized with inotropes and they're still catching up, whether blood transfusion has reached the theta, whether products are there, and I would probably wait for some more time to assess the stability of the patient, and I will try to continue this operation. Venous bleeding is something that is anticipated, so I don't think we've done any irreversible steps to that have that
So
we
excellent.
need to.
So Santil, so you continue with the resection, although the dissection was quite challenging because of the previous inflammation. Possible secondary to the CBD intervention, and GDA was flush ligated at the common hepatic artery. You resected the specimen. Post-op patient was shifted into HTU. Day 1, she remained well. Day 2, she remained well. On the day 1, you had a CT angiogram as well, just to see that there is no obvious bleeding. But on the day 1, CT angiogram was absolutely normal. However, on day 3, in the middle of the night, your registrar rings you that patient is becoming hypotensive with a blood pressure of 80/40 and a heart rate of 110. Both the drains that were placed around the pancreatic